So after prostate cancer surgery or radiation, there are two main concerns. One is urinary incontinence. Will I be able to retain my urine or hold my urine until I'm ready to go to the restroom and toilet and pee? The other concern is sexual function. Will I be able to develop, maintain, and sustain an erection so that I can have quality of life and sexual relations with my loved one? Today's conversation is with Dr. Valary Raup. She is a urologist specializing in male infertility and sexual health. She has completed her undergraduate degree at the University of Colorado, then went to Wash U at St. Louis, where she did her medical school, then residency at Mass General Brigham Harvard, and then her fellowship in male sexual health at Columbia University. Dr. Raup is particularly interested in microsurgery as well as erectile function and urinary incontinence in men after prostate cancer. We talk about specifically on how can you get a twofer. What are devices used? If let's just say in a scenario where a man has urinary incontinence and erectile dysfunction, maybe a sphincter, an external artificial sphincter is placed and a penile implant as well, so that a man can hold their urine and at the same time be able to function sexually. Again, these are surgical procedures, but fascinating conversation with Dr. Raup about that process. So please enjoy this pretty amazing conversation where we talk about recovery from urinary incontinence and erectile function after prostate cancer treatment with Dr. Valary Raup. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. Before we begin with our podcast, I'd like to thank our two sponsors for this month. Boston Scientific, leaders in penile implants through their technology, AMS 700. Ask your physician and practitioner on Boston Scientific's penile implants. And XY Vigor, Mr. Happy XY Vigor, leaders in dietary supplements for male health, and XY Vigor for male sexual health. Enjoy the podcast. Welcome to the Dr. Geo Podcast. I am your host, Dr. Geo, and you know the deal. It is my goal to help you optimize your prostate health, optimize testosterone and erections, and even how to live better with age. My guest today is a colleague of mine at NYU, and her name is Dr. Valary Raup.
That was perfect.
Is it Raup? Mm-hmm. Is that the right pronunciation? Yeah. Oh, great. Valery, you know her bio from the intro. And look, she is literally right now on call and taking time away from that, and all her patients are fine. Don't you worry, to be on this podcast today. So this is, guys, this is, I love this. This is like real life. She's on call, right next to the ER, in scrubs, and have it, in this podcast. Valery, thank you so much for being on. You're a busy woman, I know, not only doing great things in the world of urology and male sexual health, but doing great things in your own home and kind of being your own architect and construction worker and all kinds of things. So you're super busy, and I really appreciate you being on. And today you're on call, and you still said, hey, let's do this now. So I appreciate it. Valery, let's start with the big elephant in the room question, which is, to me, you're sort of like an erectile dysfunction specialist, and you're a female. My first question is why? That's definitely the road less traveled, though I know there are more and more coming up. I've had the pleasure of speaking to Helen Burney from IU. She's amazing. And there's a few others, and I'm saying, why? Like, why this? What interests you into becoming a specialist in male sexual health?
Sure, yeah, it's a good question. So I have a couple answers. The thing that drew me immediately to it when I was starting in urology residency, I trained in Boston. We saw a lot of patients with cancer at the place where I did my residency, and we took care of a lot of patients after cancer. And so the thing that initially drew me to the subspecialty was able to make such a large difference in people's lives after you've had a procedure that's, shocking and then a bit frustrating to recover from. And there's so much that we can do in the early stages, either before prostate cancer surgery or in the early stages of prostate cancer recovery after surgery, to optimize everything and to make sure that you heal in a way that's kind of ideal for you. And if erections want to be a priority for you in that time, I like helping patients through that, because you can make a really big difference and it can be pretty life-changing. And then the second piece is that when I was in medical school, rotating through urology, et cetera, I didn't really have a lot of exposure to fertility at all. And then when I went to Brigham, I had a very good mentor in fertility, and I really like microsurgery. I like the more finite physical, actual structural surgery of the subspecialty. And then also, again, you help these patients start a family, and it's all very positive and nice. So I like it for the patients mostly.
It's lovely. Now, have you ever found awkward situations speaking with a man? They're timid to speak to a female about this. They are embarrassed to kind of let a female doctor know the real deal, that they're having issues. Any sort of awkward scenarios that you've had
to
with
be honest,
patients?
I haven't had a lot of awkward scenarios. And I think part of that is because the patients know who they're seeing when they are picking a doctor. And they also are fully aware that it's going to be me, right? So they've chosen to see me. They know what my face looks like. They've found me on the internet, et cetera. The vast majority of our patients these days fit that description. When I was in training, it was a little bit different, right? I think that being surprised by having a female provider sometimes can take people off guard. But in my experience, typically, if you're personable and relatable, and ultimately you end up winning them over, even if you've kind of surprised them. But as society changes and as people become a little bit more open with the way that they speak about sex and about fertility, et cetera, I actually find that patients seek me out often as a female for a variety of different reasons. Either they don't feel as comfortable talking to a man about it. There's kind of two areas of thought with this, right? Some people find it more uncomfortable to talk to a woman, but some people find it more uncomfortable to speak to a man about what they perceive to be something that defines masculinity. And so I have a large group of patients that prefer a female. And then there's all sorts of patients who think that women listen better, think that women communicate, more kindly, less judgmentally. They don't want to see a cis male for whatever reason from their own experience in the past. And then there's the people who just, you take their insurance and they show up in your office and you're what they get. So I think that there's a lot of different reasons that bring people to our practice.
Yeah, that's wonderful. As I'm listening to you, I said, yeah, I could see also why a man would want to see a female, and kind of a little bit more gentleness, perhaps, maybe not always, a little bit more TLC, a little bit more, listening. You're right, as opposed to perhaps seeing a male expert in this area. It always fascinates me to see, honestly, even male gynecologists fascinate me. It's like, wow, why? And, why would anyone go to you, kind of thing. But there are many reasons.
I also find
for sure.
that men, I definitely think that a lot of women prefer to see a female gynecologist, but I personally have found, and maybe I'm biased based on who chooses me, obviously, that men often don't care. They're just like, sure, whoever's best. They look up your pedigree and they're like, great, this is the person for me. Or it's your availability, and they don't even think about it. They're just in your office, and it's no big deal.
Let's just say I did, you speaking to Helen, I'm like, yeah, I'm really good with this, actually. I just want to know. I think a man wants to know, the male psychology is, are you really good at what you do, first and foremost, right? You're doing if it's an implant scenario, you're doing a surgical procedure on me. Are you good, first and foremost? Secondarily, the embarrassment. I mean, at the end of the day, but I'm in the field as well. An organ is an organ. Tissue is a tissue, and I don't think I would be stuck on female versus male. But who knows? It's like when a prostate cancer patient comes to me to help them navigate. What do you think I should? What would you do if you were me? I don't know. I'm not you. Like I could say anything now, and when the time comes, like, ooh, get my prostate out. I don't know.
I do occasionally have men who come in and, you know, especially for the more like, I'm worried about the way this hangs, I'm worried about the way this looks, et cetera, et cetera. And I think that that's always a funny one, because sometimes people, very infrequently these days, honestly, but occasionally people will be like, well, you know, you wouldn't understand, you don't like, you know, have X, right? And I always respond with, you know, you've spent most of your life just looking at your one genitalia, right? Like you probably haven't spent a ton of time like looking at genitals. Whereas there are days where I see like 30 penises, 40 penises, right? So if you want to ask what normal is, I feel like there's a chance I
You
know
may have
a
an
little
idea.
bit better than you, just from exposure. Yeah.
That's right. Even despite all the
Fair.
porn you've
But that's
watched,
not
because
normal.
you know,
That's a speech I give. You can't hold that
exactly,
to your standard. You know, they were chosen for a reason. So
exactly,
mhm. Yeah.
exactly, and then all the enhancements and things with the
Yeah,
cameras and
absolutely.
even other
Mhm.
things, right? So, what is your? I definitely want to talk about a few things with you, Valery, and certainly what is your approach with penile implants. But before we get there, what is your approach with ED? Do you kind of work them up and say, all right, I have ED, it's been 3 months, whatever, I don't know, whatever or post prostatectomy, right? All right, start them on
Mhm.
daily Cialis and a VED, vacuum device. And do you have a process? Here's why I asked. I had Dr. Carrion on
Mhm.
from USF. I had Justin Dubin, and like I think before we started recording, Dr. Valenzuela is he's everything to me, because he got me started back in Washington Heights back in the day in his office in the field of urology over 20 years ago. And having spoken to all three, and worked with Valenzuela very closely, it used to be that he had his patients, who come in, and this is Washington Heights, Dominican guys. I mean, they all want this, even if they don't need it. They're all a huge line. And he said, no. You would think that yeah, sure, another procedure. No. You gotta, let me work you up. Try this. All right. Cialis, you're not working? Okay, try Viagra. All right. So he worked them up, try everything. Okay, nothing worked. Penile implant. Carrion and his colleague Crespo, who was on, they said, no. If they want penile implant, yeah, I asked them a few questions, but if that's what they want, we go for it right away. What's your approach in your practice? Is it work them up, or if you want it, you get it,
Definitely
period,
the
end of story?
former. So, there's nothing in this
Mm-hmm.
life without consequence, right? And so I think it's really
Yeah.
important as an expert in penile prosthesis to help the patients make the decision that they want, right? And in order to do that, you have to figure out what they want, right? And so I think a lot of patients want what they perceive to be an easy answer, an easy solution, exactly the same as their normal erect penis, just something that they don't have to feel anxiety about. And the penile prosthesis is excellent, 96%, 97% satisfaction rate, but in patients who are appropriate for the penile prosthesis. And not everybody is appropriate for the penile prosthesis. The way I usually describe it, and post-ED is kind of a different direction entirely, but let's just say, somebody comes in, they want a penile prosthesis. I have them try, I'm more conservative, I think, on the edge of more conservative. I have them try absolutely everything, typically fairly algorithmically, to get to the point where there are no other
Mm-hmm.
options that are satisfactory to them. Because in the patient in which the penile prosthesis is the last option, that patient is typically the happiest. And if you skip straight to the end,
Mm-hmm.
you can't go back and try the other steps later. Once you put the penile prosthesis in, you change the architecture of the corpus cavernosa, the erectile bodies, you change that sponge that's in there, and you put a device inside. And even if, you decide, this penile prosthesis isn't for me, you can't just simply take the device out and go back to where you were at the start. And so in order to prevent regret potential, I always have the patients try everything before we get to that point. The penile prosthesis is a great device, but it doesn't replicate your exact erect penis. So let's say your erections, let's call them 0 to 10, right? 0 is absolutely nothing, totally flaccid. 10 is the best erection you'll ever have, ever. And 7 is penetration. So a lot of people try to kind of focus on getting it functional. But if you have the ability to get an 8 or a 9 out of 10 erection, then your penis is completely solid, it's completely hard, and the head is also hard. And the two pieces that are different with the penile prosthesis is that your length, if you're a grower as opposed to a shower, is not always as long as your erect penis. And then also
Repeat that. Wait, grower versus shower?
Your device is going to be as long as your flaccid penis when you hold it at the head all the way out from your body. So for some people.
Hey, friends. This month is our 4-part series on the Dr. Geo Podcast on male sexual health. And with that in mind, I'd like to thank our sponsor, Boston Scientific. I'm so excited to collaborate with Boston Scientific, a leader dedicated to transforming lives through innovative and medical solutions that improve patients' lives and health globally. Erectile dysfunction, ED, is a common condition affecting 1 in 5 American men as young as 20 years old and older. If you have ED, know that it is treatable with various options such as medical solutions, natural solutions, lifestyle changes, medications, vacuum devices, injections, and penile implants. Boston Scientific's AMS 700 inflatable penile prosthesis is a long-term treatment designed to closely mimic a natural erection, providing rigidity when inflated and a natural flaccid appearance when it's deflated. To learn more about ED treatment options, visit the link below, ED Cure, or ask your healthcare practitioner for the best treatment options for you. So it doesn't make your penis look bigger or makes it bigger necessarily, like some people think.
It might make it look bigger when it's not erect, but erect and when you're trying to use it, it's going to be the same size or a little bit smaller typically. And everyone's different. It's based not on the size of your erection as much as it's based on the elasticity of your penis. And so if you hold your penis straight out when it's completely soft, for some people, that's as big as it would normally be erect, but for some people it's smaller. For some people who grow a lot, the device ends up being a little bit smaller than what they normally have. And so if you're in a situation where you have no other option, you're not able to get hard enough to penetrate, penetrative sex is important for you and is your goal, then the device is excellent, right? Because you're not trading something that's almost good enough for something that you perceive to be better. You're trading something that is definitely not good enough for something that is definitely better. And those people typically are happiest. And then similarly, the head of the penis doesn't get as erect with the penile prosthesis as it does with a natural erection. And so if you're looking at a flaccid penis that's not getting erect and that you can't have sex with, and that's what you want to do, then penile prosthesis with a slightly soft glans is great, right? Excellent. Penetrating, great. But if it's not, if you're almost there and a little bit of daily Cialis or a little bit of an extra boost before sex would have been enough to get you there, then we get disappointment. I'm not in the business of creating disappointment with invasive surgery, so I'm pretty careful. Mm-hmm.
Sure, they should be excited and very happy with what they have, right? You mentioned something interesting that I don't think I knew. I'm afraid to admit. The cylinders from the penile implant covers the whole cavernosum, but not the head. So the head in a natural erection, the shaft and the head gets erect. In a penile implant scenario, the shaft gets erect.
So the cylinders get into the mid glands. So a well-placed penile prosthesis has cylinders in the middle of the head of the penis. And so there is still some rigidity in the head of the penis, but the head itself, in the way that it engorges, that it gets larger, that it becomes more solid, does not happen with the penile prosthesis. And so that, if you're looking at a 9 out of 10 erection and you want a 10 out of 10 erection, or you're confused and you think it's going to be bigger with the device, then you get yourself into a situation where you've had a surgery that you can't take back, and you would have maybe been happier with 20 milligrams of Cialis before you wanted to have sex. And that's the situation that I work very hard to avoid. That
is great. What are the different types of implants that you would use? Yeah. Semi-rigid, rigid, what is your approach? I mean, when I was talking to the other guys, they have this rigid approach where you kind of have an erection all the time, and I was like, wait a minute, I didn't know that. And again, I work with Valenzuela and everything, and I just never seen that one, where I just seen the one that you pump, and if you want it, you pump it up, and if you want to bring it to flaccidity, you bring it down, and that's it. So wait a minute, so do you prefer one versus the other, or does it
Depends
depend
on the
on certain
situation. Definitely
things?
depends on certain things. So,
Yeah.
by and large, I preference the three-piece penile implant. So the inflatable penile prosthesis. And that's the one that you're talking about with Valenzuela, the
Mm-hmm.
one that, it's like a balloon. You have a pump in the scrotum, you have a reservoir that's hiding underneath your skin. Everything's under the skin. You can't see when it's deactivated, or even when it's activated for most people from a distance, that you have a device in. So you have a reservoir up in the belly. You have the pump in the scrotum. You pump it up when you want it to be hard, and you bring it down with a little button when you want it to be soft. And what that results in is a penis inside of your pants that's not like very pervasive. It's not, an erection that you're having to move around, figure out what to do with. I mean, yeah, all these men were teenagers once, right? You're in school, you're thinking about something, you're trying to hide it. Like, that's not necessarily a situation that sparks joy for most people, right? So for most people, I end up putting in the penile prosthesis that inflates and deflates. The scenarios in which I would put in a semi-rigid, which is the one that's kind of like a pipe cleaner that you just bend down and then bend up, that would be if the patient has some issues using their hands well. The pump is not effortless to use. It requires a decent amount of dexterity and hand strength. And so, in some situations, you have a patient who's appropriate for anesthesia, for whom sex is still a big priority, but they have really bad arthritis, they have, tremor, whatever, anything that makes your hand not work as well. Then I have a conversation about the semi-rigid, because the last thing that you would want is to put in a device that somebody can't use, right? And then the other reason why I would put in a semi-rigid is if the penile prosthesis is a big priority, but the surgical risk is fairly high. So in some of our transplant patients, in patients who have had a ton of abdominal surgery before, especially if penetrative sex is a goal, but maybe you're not with a partner who's concerned about like how strong the erection is, just whether or not it's there, whether or not you're able to do it, then sometimes I'll put the device in. But I have a lot of conversation with patients. I see patients several times before the procedure. Some of it depends on how large your penis is. Like if your penis is very, very large and you put a semi-rigid device in, then it can be, sorry, everything's falling. It can be very
That's okay.
bothersome in your pants, right? And that's a situation that we try to avoid as well. But for patients who have a lot of urinary tract infections, really high infection risk, a bad anesthesia problem, and it's really a priority, and we've had a risk versus benefit conversation, then sometimes I'll lean towards the malleable prosthesis. The other scenario is if you've had a penile implant that's gotten infected, we have to remove it, and you can put in a malleable prosthesis because it has way fewer moving parts than the three-piece penile prosthesis. And so when there's a question of an infection, we usually take out the three-piece penile prosthesis, but in order to keep the space open to kind of treat the infection and get you to a place where you can safely replace the device, sometimes we'll put in the malleable device as well, just to keep everything nice and open.
How often are there revisits in your experience, or even if there's some data that can tell us that? So, you get a penile prosthesis, and due to an infection or maybe, well, there is wear and tear. I'm assuming I think the equipment is better material than it used to be. I hope than it. So it probably lasts longer. But how often are there revisits where you have to remove one?
Sure,
And
that's a hard
insert
thing
another
to
one?
kind of blanket across. The infection risk is around 1% to 2%, depending on the study. It's higher in patients with uncontrolled diabetes or patients who have recurrent urinary tract infections, etc., skin issues, whatnot. So we try hard to make sure that your diabetes is an appropriate level. I use an A1C cutoff that's pretty low, to be honest. I use 7.58 in some scenarios. Some people will put in at 9, but it makes me nervous, and I err on the side of caution. So I usually make sure.
Hemoglobin A1C, for the audience, most of them are not physicians, is a biomarker for looking at blood sugar levels within a 3 months time, and somewhere around 5 or 5.5 is normal. 7 point, I'm not sure what's the cutoff for
6.4,
diabetes. Is it 9 or 6.4? And your
Yeah, it's
cutoff is 7?
7.5, but it's well accepted that you can do
Okay.
it in the 8s. And so I don't usually do that, but if you do that, then you'll have a higher infection risk.
More importantly, so like the diabetes is probably not well controlled. I think right. Somebody needs to ask better, deeper questions, like what's happening. Are you on your meds, or are you doing the lifestyle things?
Yeah.
What's happening, right?
Exactly.
I would think.
So
it's almost like that's an incentive to do the exercises and eat, like, stay away from carbs. Oh, wait a minute. Where does my hemoglobin needs to be? Hemoglobin A1C needs to be? You know what? Is it 6.5? I'm going to get it down to 5.5.
You are 100% correct. And I use that all the time as an incentive to get people to get their diabetes under control. Because, diabetes can cause erectile dysfunction in a huge way. And often it doesn't come back after you've had really uncontrolled diabetes for a while. So there's a very strong reality in which you have diabetes or you had diabetes, your erections are gone and they're not coming back, but you're able to get yourself in a situation where overall, from an overall health standpoint, from kidney function, from nerves, from eyes, from feet, like all the other sequelae of diabetes is much better situated and your diabetes is better controlled, and you're then a good candidate for a penile prosthesis. And so that's kind of the goal that I work towards with people. But the rates, are 1 to 2% for infection. And then as far as mechanical defect is similar, a little bit less, but that has changed with time. The devices of the past got, we used to say they had maybe a 8 to 12 year shelf life. Regularly, we see devices that are 20 years old these days. And so the devices have changed fast enough and not enough time has gone by for us to really well comment on the exact numbers per device, because it's such a scale and there's been so much progress.
Again, I always learn from you guys in this regard, because I don't do penile implants. The equipment that, let me say this: Boston Scientific is our sponsor for this 4-part series, so I want to thank them. Actually, they are excellent. For us, sponsorships are like value added. It's not like marketing. It's like, no, I've heard your product is good by experts, and let's have you on. And I know they have a product that is where they also can insert a sphincter at the same time. So after they have a patient has a prostatectomy, they have concerns over urinary incontinence, you can kind of get a twofer: penile implant and a sphincter. Number one, am I saying this even correctly?
Absolutely,
am I using the right terminology? And number two, do you use
definitely.
that?
You don't have to do them together. I don't usually do them together. I usually do one first and then the other one second. But after a prostatectomy, you remove the prostate. The prostate's like the tennis ball that sits between the bladder and the penis. You urinate through it as you pee. And when we remove it for cancer, when we remove it for enlarged prostate, we go in, we core it out from the inside, kind of like you would core out an apple, but for like a reverse core of an apple. But when you do it for cancer, you take the entire organ out. And so you spare the nerves that run on either side of the prostate. You peel them off, keep them safe. And depending on the scale of the cancer, sometimes you can keep them safer than other times. So if the cancer is getting really close to the nerves, if it's going into the nerves, then sometimes you have to take those bundles. And a lot of that dictates how well people recover after prostatectomy. So if you have a prostatectomy, let's say, where you can't spare either set of nerves, or if you have disease that's growing outside of the surgical area and you need to have radiation or something like that afterwards, in those situations, often we see a large amount of erectile dysfunction and a large amount of incontinence. And so for the incontinence, for the erectile dysfunction, you do the whole pathway, daily Cialis, add in additional meds before sex, the injections directly into the penis, which sounds horrible, but people do very well with. And then the penile prosthesis is the last resort. But for the incontinence, you can put in something called an artificial urinary sphincter, which is like a little intertube, is how I describe it, that sits around the urethra. And it lives closed. It's closed all the time. But you have a little pump in your scrotum where you can, under the skin, that you press, and it opens it up and allows for you to pee. And so it just literally sits there and squeezes your urethra closed gently to make it so that you're continent afterwards. And that, again, is something that we typically start you on a medicine that for bladder overactivity, switch up the medicines a couple of times, go look in with a camera, make sure everything looks fine. And then if you're a good candidate, we'll put in the artificial urinary sphincter.
Now, we're talking about two separate pumps. One is for the sphincter, the other
two
one
different
these
pumps,
are two different
one on
pumps.
each side.
And
they
one
look
is for
different, they feel different. People keep them straight.
Where's the pump for the
You
sphincter?
just pick a side.
Located?
It kind of depends. It's easier to use than the penile in the scrotum.
But in the scrotum
side versus the other side.
Oh,
so
okay.
I always describe it like a third testicle, and then if you have both, then you have like 3.5 testicles, because the sphincter one is pretty narrow. It doesn't really feel like a testicle.
again, the last thing I've ever want is to need any of these, obviously, right? No one does. But I do have some prostate cancer patients who scenario exactly how you just mentioned, right? So we're talking about prostatectomy, they have a recurrence, now they have EBRTs, they have radiation on the pelvic area. And they're like, yeah, now I'm really, and they're still years later, one pad a day and so forth. And so, it's very difficult to think sexuality when you
Yep.
can't control your pee. So all bets are off. Nonetheless, you may have structural issues. So it sounds like really appealing. So anything that sounds really interesting to or really appealing, my God, where do I sign up if I had to? I'm thinking, all right, I'm missing something. So what's the downside? What in terms of both, right? Is the efficacy with the sphincter not as good, or no, the satisfaction rate is high and they kind of live
No, the
a normal
satisfaction rate is
life?
very high in doing the two procedures at the same time, or, especially doing them at the same time, but also doing them one after another. The biggest risk of both procedures is infection, more so the penile prosthesis, but definitely also the urinary sphincter as well. And so by going into a well-healed, non-infected penile prosthesis and going in and putting in an artificial urinary sphincter, you always worry about super infecting one versus the other. And so that, I think, is probably the biggest big concern. The downside to the sphincter, the sphincter is awesome if you're a good candidate for it. It is, of course, more annoying to have to press a button to pee than it is to just pee. But if you're having large volume incontinence, if you're going through several pads a day, then it becomes something that makes sense. The biggest downsides of the sphincter, especially if you've had radiation, is that you're squeezing it all the time. And so those tissues, after they've been radiated, don't typically have the best blood flow. And so you're at a higher risk of erosion of the device into the urethra. So we're very careful about sizing the device, trying to make sure that it's the right size, that it squeezes the right amount to keep you dry, but also to not squeeze so much that it can eat into the urethra. And then also you always worry, like if you get old and your hands stop working and you no longer, want to use your penile prosthesis, it's fine to just let it sit there. It doesn't have to be removed or anything. You can just ignore it and pretend like it's not there. But for the artificial urinary sphincter, there's kind of a sweet spot as you get older where you want to make sure that people are still remembering that they have a sphincter and that they need to use their sphincter to pee. Or if you're in the nursing home and not everybody's completely aware of your whole medical history, et cetera, sometimes we'll leave those deactivated later in life. But yeah,
that sounds like there could be eventually potential problems. Now, can just like the penile prosthesis, once you have a sphincter, that's it, that you can never go back and you have to always depend on something, or
no,
you're not
not
going to be able to
necessarily.
control
Not
your urine,
necessarily.
or how
Usually the
does
sphincters we don't put in unless it's less common for a patient to come in urinating pretty well and be like, I want a urinary sphincter, right? All the time, people that come in with mild erectile dysfunction, or they haven't tried all the treatments for erectile dysfunction, they read about the penile prosthesis and they're like, that sounds awesome. I want that thing, right? And so I just feel like we don't have to do as much redirection and re-education for the sphincter than we do for the penile prosthesis, because it's so much less common to have full incontinence than it is to have mild ED, right? Erectile dysfunction is incredibly common. The numbers are, as high as like 60-70% of people have had ED at some point in all age groups, right? And the things that cause it so often are, of course, like big things like
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going to the pelvic area for better erections. Try Mr. Happy XY Vigor today.
The structural surgery type stuff, or big medical issues like diabetes, heart disease, et cetera, but also just being stressed out about whether or not you're going to get an erection is well and away enough to make you not have an erection, right? And so in that situation, we're really careful about putting in a penile prosthesis because you might be stressed now, but you might not be as stressed later. You work out the situationality of all of it, make sure that it's a good option.
And so, just so that I'm drawing an image as to how the process works, you're inserting both the sphincter, urinary sphincter, and the implant in one surgery.
Don't. Yeah, I usually do
It's
them
not
in two separate surgery.
It's two
can
separate
choose either
visits?
way. I typically do them in two separate surgeries because it's a little bit, it's more elegant for me. I worry less about it. We do one at a time, one recovery at a time. Doing the two together is a lot of time in the operating room. It can have a potential for a higher infection rate, but it's just more difficult to recover from as well. So I've, to be honest with you, only seen once or twice them be put in at the same time. I've never done it myself. I typically stage it.
So that's interesting to me, right? So here's the scenario. Dr. Raup, I just had a prostatectomy. I don't want any more surgical. I don't want any more surgeries in my body if I can avoid it. Okay, you know what? I'll do the penile implant. That's one. And then come back for just 3 surgical procedures. I can see the patient say, oh man, this is, meanwhile, potential significant improvement of their quality of life. But they're like, surgical procedure, is too many. I'm done with surgeries. So you're saying, yes, it can happen. Yes, you can do, but you can insert both under one procedure. Don't like to do it because I like them to recover longer time in the OR and things like that, but possible. And you also mentioned, correct me if I'm wrong, sort of the patient is involved in that decision making as well?
It's uncommon for patients to decide that they want surgery for incontinence and that they want surgery for erectile dysfunction at exactly the same time. You recover much slower. You recover your erectile function much slower after the prostatectomy than your continence. And so the continence, usually we kind of reach a maximum success around 6 to 8 months after the surgery, whereas you can continue to get improvement in your erections for even past a year after the prostatectomy. And so typically patients are very open to doing one surgery at a time. I usually start with the artificial urinary sphincter if their incontinence is driving them crazy, but it's based on what's bothering you more. Which one's bothering you more, right? Is the erection problem bothering you more? Is the incontinence problem bothering you more? Because often they're a little bit intertwined with each other.
Absolutely. They're very much intertwined. And as I said, if you have urinary incontinence, you're not really thinking of erection. Some guys are, however, but not most. You have different We're in New York. We see all the different personality types and people have different interests. The only element as it relates to fertility that I want to touch on is probably the obvious, but I've learned never to think that anything is obvious because most people, we live in a homogenous world in our clinics and most people don't know. Fertility is definitely out of the question with any of these procedures, right? I guess if someone is young enough, they have to save their semen in a sperm bank and so forth. Is that correct?
Well, you can stay fertile with a penile prosthesis. You still ejaculate, you still have sensation. So putting in a penile prosthesis would not preclude your fertility. Technically, when you do a prostatectomy, you remove the prostate and the seminal vesicles from both sides, but you don't remove the testicles. And so if you were to have a lot of radiation, there would potentially be some damage to the testicles, but just a run-of-the-mill prostatectomy, you can still get sperm directly from the testicle to use for fertility, and that sperm is still intact. It doesn't have any ejaculate that it connects to, but it still lives in the testicle and it can still be extracted from the testicle. That sperm.
Okay, got it. So for clarity purposes, that's very important. There's still sperm in the testicle. Not that you can ejaculate after a prostatectomy and be fertile, but you would have to extract the sperm from the testicle and then save that, and then that could be used for fertility.
You can actually extract it later as well. So if you decide after a prostatectomy that you want to try to have a baby, you can get sperm after the prostatectomy has been done. But that sperm, when it comes directly from the testicle, it doesn't mature fully, so it doesn't have fully functioning tails. So it's not sperm that you could like turkey baster in, do intrauterine insemination, have it swim to the egg and fertilize. You do have to use it exclusively with in vitro fertilization, and actually a slightly special type of in vitro fertilization where they take the individual sperm with its little half tail that they make sure is alive by getting it to twitch with something called patoxyphylline. But they take what they've perceived to be a live sperm and put it directly into the egg with the teeniest little tiny needle under a microscope, and that's how they get fertilized. So it's a little bit more complicated.
All right. Again, this is so, and I would have started podcasting 10 years ago if I would have known that amazing people like you would come on and I would still be learning, right? Because after a while, I was like, how much can I learn in this space? Always learning.
Mhm.
Prostate, testosterone, always learning.
Mhm.
In an in vitro scenario, you really don't need the tail. I never thought of that, of the sperm. But you're saying, do they keep a little bit of the tail? Is that
You
even
just need to
necessary
figure
or
out the
no?
sperm that's grown enough to be alive, like grown enough to succeed. And so it's difficult in the testicle to figure out because you don't have like a little wiggling fully formed sperm. It's difficult to figure out which ones
Sure.
are viable. So which ones are advanced enough in their development process and have succeeded well enough to have like a fully formed genetic material, enough stuff to actually fertilize the egg. And so typically we try to use the sperm that are twitching. So they don't always twitch right away, but the embryologists do all of this, and we have great embryologists that we work with. So the embryologists put like a chemical kind of, I guess, for lack of a better way of describing it, on the sperm to try to promote them to come alive a little bit. And then the ones that are making some sort of movement are the ones that they use. So it doesn't have to be a fully formed wiggling tail, but it's easier and better if there's some semblance of a tail in order to allow it to twitch a little bit. So it's not like a full one like you'd see on the TV. It's just like a
Yeah.
halvesy.
Gotta love it. Gotta love it. I think that we had, I wouldn't say a master class on penile prostheses versus, or penile prostheses, urinary sphincters after prostatectomies. I wouldn't say it's a master class, but man, this was excellent. And as it relates to fertility, and that last part was amazing. I want to thank you so much. Look, I love the authenticity of this conversation and interview. You are in the hospital, people walking
Sorry.
in and out, the door is squeaking, your residents or fellows or whoever coming in and out, nurses. I got to tell you, I love it. This is real life scenario right here. I would almost rather do it this way than, a fake
Good.
background and things like that. So I really appreciate you taking this time, Valery. Busy day on call. You have a patient waiting for you with a stone while you're on call, and here you are. Final words, if you have any, and how can people find you if they
Sure,
want to make an
yeah.
appointment with you?
Just this is a topic that I think that a lot of people are really nervous about talking to somebody about, and we just encourage you rather than waiting to just find a doctor who either specializes or doesn't specialize. Even just talk to your primary care doctor if you don't know where to begin. Just tell somebody if you're struggling with either fertility or with erectile dysfunction, and let the medical system help find the right person for you. And if you don't want to go out and find them yourself, we're all very Googleable. You can just Google our name. Our website at NYU comes up. You can make appointments directly through the website, through Find a Doc. You can call our office. Most of us see patients at different sites, and so typically there's somebody near your house, especially in Manhattan, who's available to see you. But just don't hesitate to, if you're wondering, any question is not too small. If there's something about your overall men's health situation that's bothering you, just make an appointment. And the worst thing you can hear is that it's normal. Right?
Dr. Valary Raup, Valery, don't limit yourself to Manhattan. This
Good.
podcast is global, and somebody may say, "This girl gets it. I'm going to her from anywhere. I'm in Germany. I'm going to this. I'm going to her to get my situation fixed." So once again, thank you, Valery. I appreciate you and
Perfect. Thanks
everything
for
you do.
having me.
Thank you, everyone, for listening and watching this episode of Dr. Geo Podcast. Always a pleasure to serve you, bring a lot of value to you, things that you're not going to see or hear about anywhere else. This is, we go narrow and deep here in Dr. Geo Podcast, and we get the best of the best. So thank you for tuning in. Don't forget to like and subscribe on whatever platform you're on, whether it's YouTube, Spotify, or Apple Podcast. And, drop a comment. I read them all. Cannot reply to all, but I do read them all. And if I can, I will reply to them. So thank you so much. This is Dr. Geo signing off. Much love. Talk to you next time. Thanks for tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.